glad to see this very successful meeting full of people at this time of the day. I'm going to talk about the mitral regurgitation, timing and choosing what's the best therapy. And the problem with the mitral valve, it's a complex structure. And like we have the leaflets, the ring, the chordae, the papillary muscle, the LV, any problem happens in those, or even the LA, that can cause a mitral regurgitation. And it's really the commonest valve pathology that we have. And the mitral regurgitation is associated with a poor survival, even mild mitral regurgitation. And as the amount of regurgitant volume becomes more, we know the survival decreases and hospitalization and comorbidities increases. And that's why we have those numbers, which is the effective regurgitant orifice area that we'll see later on. We chose 20 as that amount starts from 20 and goes up, the outcome becomes poor. The problem with the mitral regurgitation is lots of patients, they don't get the therapy. And the reason is as the patient gets more comorbidities, the chance they will have surgery to fix their mitral valve is less. Or if their LV ejection fraction is less, their chance to get it fixed is less. And if they get older, their chance is less. So there are lots of patients that they don't get treatment because of different reasons. And people who doesn't get surgery or therapy, their outcome over 5 years is really bad. And again, the mitral valve is not one animal. It's different types. And why we should separate them, because the pathophysiology is different, the treatment is also different. So we'll divide them into two types, primary mitral regurgitation and secondary mitral regurgitation, or you can call it degenerative mitral regurgitation or functional mitral regurgitation. The criteria to diagnose it is almost the same, but the mechanism is different. Primary or degenerative is basically disease of the mitral valve leaflets, whereas the secondary or functional is the disease of the LV itself, or maybe the LA. We'll start with the primary mitral regurgitation. So we'll go directly to the topic of this lecture, is when to intervene. There are 3 things that we should look at to decide to intervene or not. Symptoms is 1. Factors that are associated with worse outcome is 2, despite of symptoms. And there is a special group who are asymptomatic. So if you look to the symptoms is shortness of breath. And basically, if you look to the differential of shortness of breath, is really long list. So if you have somebody with significant severe mitral regurgitation and you want to decide whether this shortness of breath is due to that mitral valve regurgitation or not, sometimes you may have to do hemodynamic study to evaluate the left side pressures and the transpulmonary gradient to decide whether this shortness of breath is really due to the mitral regurgitation. There are other factors that will affect your decision whether to intervene or not, which is factors associated with severe mitral regurgitation. One of them is the LV ejection fraction. When the LV ejection fraction starts to drop, this is a sign you need to intervene. If the LV end systolic dimension becomes more, so the LV start to dilate, this is another reason. The LA size, pulmonary artery pressure, or other reasons, and new atrial fibrillation. Then we have this group of asymptomatic patients. When you ask the patient, they are asymptomatic. Sometimes they are asymptomatic because they think the shortness of breath they have, it's due to age, this is natural. When you ask them, they will tell you, oh, I'm fine. So there are other things that can help you in that. One is you can look in the echo and look to the global longitudinal strain. This is the earlier sign of LV dysfunction before the LV dimensions or LV ejection fraction drops. So when you see that in somebody who's asymptomatic, that means that he starts to have the damage to his ventricle, you have to intervene. The other thing is the nitroureteric peptide, and sometimes you have to do cardiopulmonary test to unveil the symptoms. And if the patient is truly asymptomatic, you do all of that and you decide this patient is truly asymptomatic. Even those patients, if we look to the MR in those patients, people who are class 1, if we look to their outcome, who are truly asymptomatic, they have bad outcome on the long term. And if we look to patients who call themselves class 1 and they had surgery, they also did worse on the long-term outcome. So basically, asymptomatic patients, they may benefit from intervening early. So what type of intervention in those group of patients? 1, medical therapy, 2, surgical, and 3, percutaneous. So if you look to the medical therapy, the only medical therapy that is having some evidence in degenerative mitral regurgitation is beta blockers. This is the only drug that, or group of drugs that may help the outcome in patients with primary MR. Other medications, there is no evidence of it. Afterload reductions, whatever is the type of medication, did not help the prognosis. Now, if we talk about surgery, we know that mitral valve repair is superior to replacement, and the outcome is good, actually. And here we have clear data that mitral repair in primary or degenerative mitral regurgitation is better than mitral valve replacement, and regardless of the age, still it is a better option. The problem when we talk about repair, it should be repaired by an experienced operator. And when we talk about experienced operator, we have to look to the volume of the surgery that has been done. And we can see here in this slide that the more surgeries done by the surgeon, the better outcome if we look to the left side of the screen. And the cutoff number has been put was 25 mitral valve repairs per year to be called a experienced operator. And there's a nice paper, they put a standard or proposed standards to experienced centers. And basically, it's the volume per surgeons more than 25 or 50 per hospital with mortality less than 1 and reoperation less than 5% per year, per 5 years. So this is the criteria to call somebody is experienced and send somebody to experienced surgeon or a center if he's truly asymptomatic. Then if we talk about the transcatheter option, the data comes from Everest 2 trial, which is the mitral clip was first tried in primary PCI, primary mitral regurgitation. And basically, those are patients who are surgical, and they compared the clip to mitral valve repair. And the results, the clipping to the mitral valve is safe, and clinical outcome is the same, but patient with surgery, they had better or less mitral regurgitation on follow-up. So people with mitral who got the clip, they had more mitral regurgitation on the follow-up. And that has been maintained over 5 years. So surgery, steady, maintained, whereas the clip, they have more MRs. So if we look to the guidelines, so class 1 is if somebody needs a repair, should be referred to a center that is experienced and we predict durable outcome. And we have talked about the criteria for that. And then if the patient is symptomatic, this is class 1. And if the patient is asymptomatic, we look to other criteria, which is associated with bad outcome, class 1 and class 2A. And if the LA is enlarged, it's class 2A as well. And if the patient is not surgical, so then we think about percutaneous intervention. And if we look to this diagram here, is basically the treatment of primary mitral regurgitation is surgery. Unless we cannot do it, then we go for a percutaneous option. And then we come to the functional MR, which is not as straightforward as the primary MR. And the functional MR is a disease of the left ventricle or left atrium. And basically, if the left atrial enlargement happens with atrial fibrillation, the annulus can get dilated. but the LV size will be still preserved and normal. So those patients are treated as heart failure with preserved LV function, and surgery versus percutaneous treatment are the options, with no evidence on either, and we didn't have any comparison. Then we're going to talk mainly on the functional MR due to the left functional dysfunction. We know as the ventricle enlarges, the MR increases, or it's vice versa, we don't know. As the MR increases, the LV drops. And if we look to the all-cause mortality, okay, it's gone. We can see in patients with LV dysfunction, even mild mitral regurgitation increase the mortality and decrease the survival. So the goal of treatment in people with secondary mitral regurgitation is to improve symptoms, quality of life, reduce the heart failure admissions, and improve survival if we can. So the first and mandatory and essential treatment to functional MR is medical therapy. So we should start with medical therapy for LV dysfunction that we all know: ACE, ARB, Entresto, GLP-2 inhibitors, ivabradine, and cardiac resynchronization. So medical therapy is the essential treatment. And we can see medical therapy results and mortality benefit is way better than mitral clip. So we should concentrate on that. And this is the result of a trial comparing Entresto to valsartan in people with severe MR and a LV dysfunction. Cardiac resynchronization also, it helps. And if medical therapy does not, patient still symptomatic with CRT criteria, we should proceed with that before thinking of surgery or percutaneous intervention, because we know that resynchronization improves mitral regurgitation. The problem with all of the medical therapy that we think or we believe it is essential, mortality, even in those patients who are treated well with medical therapy, is really poor. So we can see the survival at 5 years is almost 50%. What's the role of surgery? So annuloplasty, which is mitral valve repair with annuloplasty, did not show any benefit in those patients. If we compare mitral valve repair to mitral valve surgery, there is no advantage of either over each other. And sometimes patients go for CABG and they have moderate MR, and on the way they just fix the mitral valve. Does that really help? Actually, there is no data supporting that. So mitral valve repair and moderate MR in patients who are going for CABG does not improve the outcome. So what about isolated CABG versus severe MR or moderate to severe? Again, it did not really help. So adding mitral valve repair in those patients increase your clamp time. It did not reflect on clinical outcome. And even with severe MR, it did not really change the outcome, adding mitral valve repair to CABG. And that's why if we look to the guidelines, in the ACC guidelines, it's saying there clearly MR in the setting of CABG, class 2A. And basically, it is reasonable to avoid leaving a potential severe MR despite the absence of conclusive evidence that this approach prolongs life or improves symptoms. What about transcatheter options? You can see there are lots of them. So on the left side, this is 2 clips or 2, we call them edge-to-edge repair, transcatheter edge-to-edge repair, which is the mitral column Pascal. In the middle, there is annular reduction devices, and on the big one is multiple percutaneous valves. The ones that are standing now and having better evidence are the edge-to-edge repair and couple of the valves, interpret and tendine. And the evidence in edge-to-edge repair comes from co-op trial. There were 2 trials were parallel to each others. One in Europe, one in the States, one called co-op, and one Mitra FR. And basically one of them was negative, Mitra FR, and co-op was positive, survival and hospitalization. And that was maintained over 3 years. And if we look to the why that difference happened, and maybe that should teach us how to approach those patients. So patient in the co-op trial who had the benefit are patients with more regurgitant volume, less LV dilatation, so they did not wait on the LV until it gets bad, and it was mandatory to treat them before going for the procedure with guideline-directed medical therapy. Whereas Mitra FR, it was optional to titrate as you like, and the LV was more dilated, and the regurgitant volume were less than the co-opt. So what do we learn from that? Means we have to intervene on earlier stage. Like if we look to this diagram, if we look to the green square, it's basically people with moderate to severe MR and their EF more than 20, and LV ejection and the systolic dimension is not more than 70. Whereas in Mitra FR, their LV dimension was more than 70, which is very dilated. So if we go to the recommendation here, it's more confusing actually than the primary. So the only 2 recommendations is class 1 telling us we have to intervene if patient is symptomatic with despite optimal medical therapy. And they did not really specify which is it surgery or percutaneous. And the other one, which is the other one that we discussed, class 1, if the patient is going for CABG and he has severe MR, we have to intervene. This is class 1. Then the other recommendations is basically, it's not clear. It's just you can do either or surgery in those patients. And if you look to this diagram, it's not as simple as the primary because it's more confusing. And basically, there is no clear recommendation beyond medical guidelines, what should you do. So the take-home message, primary mitral regurgitation treatment is surgery. If the patient is not surgical, then we can refer him for percutaneous intervention. In secondary MR, first treatment, first line is medical therapy. If medical therapy fails, then transcatheter mitral valve repair is the second option. If the patient is going for CABG with severe MR, then the mitral valve, maybe fixing it is beneficial despite no evidence. Thank you very much.